questions that come up. But I wanted to start today with some program updates, and then we'll also go over some House Bill 70 updates, as there were some changes made to the legislation when it comes down to providers getting connected. And then lastly, we'll actually have Deborah Farrington, North Carolina Medicaid Chief of Staff, join us to talk about some high-level Medicaid transformation changes. So lots to cover today. We'll try to get everything in and get answers answered too, or leave some time, I should say, for Q&A. But I'll go ahead and get us kicked off with some program updates. So I wanted to make sure everybody had that information also. And then once again, just as a reminder, if you can, mute your line. We hear some background noise going on now. We try to handle it on this side, but sometimes WebEx does kind of let you as a user override our mute. So if you can help us out by muting yourself on that end, that will be great too. And then once again, you can use the chat function throughout the presentation if you have questions come up. All right, so I'll go ahead and get started. So one, I wanted to start off with many of the program updates when it comes down to deadlines. I know we get a lot of questions about that here at the Office of Rural Health as we've been providing technical assistance. So I've tried to put the dates that are critical in red. So right now we're in June, so this is the month that you do need to make sure that you have selected your electronic health record vendor, so your EHR vendor, and that you're letting your rural HIT specialist, if you're a part of the funding program, letting your rural HIT specialist know what that EHR vendor name is and who you have selected. Of course, you have AHEC practice support that is available, the area health education centers that are available to help you through this process. I know many of you have been working with AHEC, which has been great. We have received some great feedback there of a lot of the support in just implementing an EHR and making that a part of your workflow. But this is the month, June, but really before the end of the month, if you can let us know, that would be great. Many of you also have already signed in your participation agreement for NC Health Connect, our statewide HIE. That was a deliverable that was due last month. If you have not done that, or if you have questions, please reach out to your rural HIT specialist, because we want to make sure that no one gets left behind there. And then lastly, this is a kind of a newer date. We wanted to give as much time as we could for those recognizing that, we do still have some program participants that are just selecting their EHR. September 2019 is that last date for you to incur any costs and submit documentation to the Office of Rural Health in order to get reimbursed for your EHR-related expenses. So just make sure you mark that date down to September is kind of our final date. If you can get in your expenses ahead of time, your receipts and stuff, of course, that's helpful for us also, just so we're not pushing it down to the wire here, but that is kind of our final cutoff date if you're looking to get reimbursed through this program. So I know we did get a chat question there. Is it September 1st or the 30th? We will go through the end of the month of September, so thanks for asking that, Mark. But yeah, that would be kind of our final drop dead date to make sure that you do get reimbursed for those expenses. So thanks for asking. Okay, and if you have other questions too, you can chat those in as we're going through. I'll try to keep an eye on the chat window as we go through. Some other quick things I wanted to go over for the program, just a lot of questions, frequently asked questions we get are, how are those reimbursements made? And just a reminder that the reimbursements are made through NC Track. So when you submit your final expense report to your rural HIT specialist, just make sure that org NPI number that you put on your expense report and the bank account that's affiliated in NC Track with that particular NC Track org NPI number, that those are updated and matched, because we just want to make sure that you're getting your reimbursement in the right account. So questions about that, of course, your rural HIT specialist can help you out. But just wanted to make sure that those things are up to date, because we've, for the most part, have had successes, but we did have one participant that, unfortunately, their bank account number wasn't updated, so we had to kind of track those funds down. But all that's to say, let's just proactively make sure that you guys get that done. I do see a question, the chat also, about how to submit your receipts. So those receipts can be submitted to your assigned rural HIT specialist. We've been receiving most of those via email. So that is something that you can, those receipts that you have for any expenses that you have incurred in getting connected to NC Health Connect, you can submit those EHR receipts to your rural HIT specialist. The other thing I wanted to just bring out is many times we'll get questions about, okay, exactly what do I need to do in order to be ready for reimbursement? So really it's 3 steps. One, we're looking for just proof of those EHR costs. So that can be your receipt and paid invoice. If you go ahead and submit that to your rural HIT specialist, assigned rural HIT specialist, we're looking for your fully executed Health Information Exchange Participation Agreement, or what we call the PA. So if you'll, as soon as you send in your PA to the Health Information Exchange Authority, within a certain amount of time, you'll actually get back a fully executed copy. And fully executed is just saying you'll see your signature on the signature page along with the executive director signature for the HIEA, and that's what we're looking for, that fully executed copy to show that the HIEA has received your PA. And then lastly, we are going to be verifying that your EHR is able to connect to NC Health Connect. Those are the 3 things needed for reimbursement. And once again, if you have questions, you guys can chat these throughout. And then lastly, I know we get a lot of questions too around, all right, what are some examples of some of the items that I can submit for reimbursement? So it can include really anything related to that EHR implementation and setup fees. So these are just some examples that we have here on the slide. But then also we recognize that many times that also getting a new EHR involves getting laptops or tablets or servers or printers and scanners just to kind of help with that workflow. So those are also eligible for reimbursement. So just note though that any of the expenses that you're submitting to our office for reimbursement, they do need to be associated with getting connected to the HIE. And I wanted to give you guys a snapshot of where we are with the active participants in this reimbursement program, just to give you an idea of where everybody is at different stages. So we still have about 14 organizations that we have not heard from insofar as you sending in your PA. So if you have not sent in your participation agreement, please make it a point to reach out to your rural HIT specialist and get that done. And then the others, we have about 83 participants that are in the EHR selected and the participation agreement signed stage. So great, looks like we're making progress there. Just let us know once you actually have selected your EHR. And once again, that should be done by this month, June. 15 that we see that are under review right now by the HIEA, the EHR you selected. That just basically means that we need to verify that the EHR that you have selected is able to get connected to NC Health Connect. We've got 32 program participants that are ready for reimbursement, so you're just gathering the documentation and receipts that you need in order to be reimbursed. And then lastly, we've got 25 participants that have made it across the finish line. So you are reimbursed and actually have selected your EHR and sent us the receipt. So wonderful to see that number growing. So we'd love to see everybody get across that finish line. And as we mentioned earlier in the call, that last date to submit those receipts is by the end of September. Okay. So just a reminder for your rural HIT specialists, we've included their information in the slides here. We are split up into regions, so wherever your primary practice, when you applied for this particular grant, wherever your primary practice is located, that's who you will be aligned with as your rural HIT specialist. Of course, if you have questions about who is who, just reach out to any of us and we'll get you plugged into the right person. But just you're either working with Sebastian, Adonica, or Adam, and they're actually here on site too today. So if you do have questions, you can chat those in and we'll answer those for you. All right, and lastly, once again, this is our last monthly webinar. So any of the webinars that you may have missed or you want to go back and see, they are available on the Office of Rural Health website. So those are, even today's webinar we are recording, so that will be available after today's presentation. Just give us a little bit of time. Usually it takes a little time to get those uploaded to the website. I would say usually within about 2 to 3 weeks, but we'll send you an email once it's ready to go. All right, so I'm going to get ready to pass the baton to Kenya Servia, who is with the HIEA, Health Information Exchange Authority Outreach Team, and she's going to share some updates on House Bill 70. That was recently a House bill that went over what we call the HIE Act and some changes there. So Kenya, take it away.
Give me just a second.
Okay.
If you want to ask questions while I set the WebEx to view the next presentation, just a moment. Is it showing correctly?
Yes. Yep, we can see it.
Okay. I don't mind. But anyway, good afternoon, everyone. This is Kenya Servia, as Lakeisha just stated, with the North Carolina Health Information Exchange Authority. It has been a fun ride these last 6 months, working with you all and hearing from you via email and phone call. And we will be available for your assistance as the time continues, as you continue to work through your implementation process. But as Lakeisha stated, I'm here just to give updates on House Bill 70. It was a long ride before it actually was signed into law last Friday by the governor. So one second, I realize that the slides are not progressing, but I am progressing them on my screen. So let me find out why it's not progressing. One second. Okay, now let's see.
Yay, we can see it
All
now.
right.
Yep, we're with you.
So, as stated, House Bill 70 was passed into law last Friday, and the first thing I want to explain is that it clarified the language that the law is only mandatory for providers who are within North Carolina. So any provider that is in our bordering state that would like to connect, they may connect voluntarily, but it's not mandated for them to connect to NC Health Connect. In addition, the biggest highlight was that it pushed the connectivity deadline from this past June 1 of 2019, and it moved that connectivity deadline for all Medicaid and state-funded providers that were due to connect on this June to next June. So that we're the most excited about because it gives you time to really understand what Health Information Exchange is and how you can benefit and your patients can benefit by participating in Health Information Exchange. It also explained if you are granted a hardship exemption and there is a extension until 2022, and it also clarified that the information that passes to and through NC Health Connect is not a public record, and therefore it's not subject to any public records request by an outside entity. In addition, it only requires healthcare providers licensed in North Carolina. One second. Here we go. So it also stated that there are certain providers who can request that hardship exemption. For instance, if you are nearing retirement or your facility is to close or due to close in near future, you may apply for that hardship exemption. If you lack affordable broadband in the area where you're located and you won't have access to that, you will be granted a hardship exemption again until December 31st of 2022. And if there is a financial hardship for procuring an EHR. And again, the Department of Health and Human Services, along with the Department of Information Technology, are working together to develop the process for applying for these hardship exemptions. We have had several providers to reach out to us to find out what that process is going to entail and who they will contact. Please stay connected with your rural HIT specialist. As soon as we know more, we will be contacting you via our updates with the Department of Information Technologies, NCHIEA updates. It will go out with NC Tracks, and your rural HIT specialist will notify you of the procedure for applying for the hardship exemption. Now, there were several providers that were mandated to connect initially. However, they have been granted the exemption, and they no longer have to connect at all, but they may connect voluntarily. And before I go through the list of who may connect voluntarily, let me just explain to you that if you have submitted a participation agreement and would still like access to our clinical portal, you may have a full participation agreement, not integrate your EHR. Just let us know that you don't want to connect with your EHR if you fall under these 10 exemptions, and you can still have access to our web-based clinical portal, as well as our event notification service, NC Notify, and you can still benefit from the other value-added services that are available to full participants without having to integrate your EHR. Again, it will not contain the information from your facility because you won't be sending any data, but you will be able to have access to that for the services that you provide to your patients. So those participants that are no longer mandated to connect included community-based long-term services and support providers, including personal care services, private duty nursing, home health, and hospice care providers. Intellectual and developmental disabilities, even some of you that may have obtained the grant from the Office of Rural Health, may not be mandated to connect, but you can connect voluntarily. Again, support providers such as day support and supportive living providers are no longer mandated to connect. CAP-DA and CAP-C providers may connect voluntarily, as well as innovation waivers. Eye and vision providers, speech, language, and hearing service providers, OT and PT, as well as durable medical equipment, non-emergency as well as emergency medical transportation providers, and lastly, our local education agencies, as well as school-based health providers. I do want to clarify for school-based health providers, because we had these questions to come up, that includes both physical and mental health school-based health providers are no longer mandated to connect, but you may connect voluntarily. For example, if you are a school nurse and you would like to benefit to see the clinical portal for students that you're treating, if you'd like to complete a full participation agreement, you can still view that longitudinal patient record for your students, but you no longer have to integrate an EHR. Now, the extension process, I've explained to you the timelines and when everyone wants to connect. And now that everyone's mandated to connect on June 1 of 2020, the previous extension process is voided, but you will be able to obtain a one-year extension after June 1 of 2020 if for some reason you are not yet connected to NC Health Connect. Please note that this is not an exemption, just merely an extension of time to allow you time to build your connection. So in the event you have questions and you want to learn more, our website, we've shared this with you before, but just want you to know that you can see the providers who are connected on our website, as well as it comes in the form of a map or a table. You can search for the provider by provider type, or you can search for your name if you want to know where you are in the connection process. And that's all listed, and you can even see that if you look at the spatial dots on the map, that's geographically, so you can see how many providers are connected in your area and what their provider types are. And if you have any questions, our website is updated regularly, and it contains all of our contact information, and it's a great place for you to gain more information about all things NC Health Connects and NC HIEA. And lastly, our monthly How to Connect calls will still be happening each month on the last Monday of the month from noon to 1 p.m. We host this 1-hour call where we explain to providers about who we are at the North Carolina Health Information Exchange Authority, what Health Information Exchange is, how to connect to the Health Information Exchange, and more. If there's any updates, we typically share those during that call. It normally lasts about 35 minutes at the beginning, and there's plenty of time at the end for questions. So I encourage everyone to not only listen once, but to join a couple of times just to get a chance to really understand, because I know it takes a while before you really start understanding exactly what Health Information Exchange is. And that is all I have, but you do, if you have any questions in the chat, did anyone see any?
Yeah, you do have one.
Jane Hollow say, what if you are a IDD provider and provide state-funded services too?
Even if you are an IDD provider that is funded via the state, if you were granted an exemption via House Bill 70 passing into law, you're no longer mandated to connect. But there are many benefits for IDD providers who choose to connect voluntarily. And as stated earlier, you can connect with a full participation agreement and not submit data. You don't have to integrate an EHR, but you can gain access to our web-based clinical portal, and you can utilize our value-added features. So there are benefits for you for connecting, but you don't have to connect by law any longer.
I think that was it.
All right, give me.
I think, Philly, we did have one more come in.
Okay.
You want to read it, Sebastian?
Okay, Liz say, for IDD providers that are not mandated to connect now, but have gone through this process and have submitted receipt for grant funding, will we still be reimbursed even if we do not integrate our EHR and only use the web access?
Yeah, so if you've already gone through the process and you've already procured an EHR, yes, you would still be reimbursed through this program. Because like I know the House Bill 70 updates just recently happened. So yes, if you've gone through the process of getting connected to NC Health Connect, as long as you've still met those criteria for reimbursement, that you've sent us your receipt, that you've signed that participation agreement with the HIE, and that your EHR technically can connect. Granted, it doesn't sound like, Liz, you're going to actually connect it, but as long as you meet the program criteria, you would still be eligible for reimbursement. And that brings up a good question, and I haven't seen it in the chat, but as Kenya was going through the new dates for House Bill 70, just recognize that the dates for this program reimbursement are still time limited. So even if you're a provider that now doesn't have to connect, or you have now more time to get connected, our funding is still finite. We have an end date on this funding, so you would need to have procured your EHR and any expenses associated with that by the September date that we went over earlier in the presentation. So just recognize, I know there's a lot of dates out there, but this funding source is time limited. If you decide not to still move on with this program and the funding, because you do have more time, just let your HIT specialist know that. But if you are looking to still get reimbursed through this program, you will need to hit the program date. So. All right, I don't see any other questions now in the chat, but if you have any others that come up, let us know. We're going to get ready, and I know we might go a little over time today, but just by popular demand, topic that has been coming up a lot has been questions about Medicaid transformation. So I wanted to introduce, We have today with us Deborah Farrington, who is Chief of Staff of NC Medicaid, that will go over some brief NC Medicaid transformation, frequently asked questions, I guess, that we've gotten that we shared with Deborah and her team, and then also give you some resources for getting more information on Medicaid transformation. I'm going to see if I can share my screen because we're having a little technical difficulty trying to get it going off of the screen we were on before. So just give us one moment and we'll go ahead and share Deborah's slides. And I should be able to just share, right?
Because it's not letting me
do it and do anything. All right.
Well, in the little windows before, you don't click exactly in the blue share. I don't know.
Okay, so sorry about that. We are back to sharing, so hopefully you guys can see our screen now, and I'll pass it over to Deborah.
Thank you. It's a pleasure to be here, and thank you all for this time to talk a little bit about Medicaid transformation. For those of you who have heard some of the information before, I just want to make sure that I cover some background information as a point of level setting so that we're all, just on the same page about what's happening with the implementation of managed care. So what I do want to talk about, as I mentioned before, some background information. I'm going to talk about what our priority objectives are in the coming days and months, and then what are some of the current activities that are ongoing to support this transformation, as well as what you can look forward to as some coming activities in the next few months. I'd like to share this vision statement because it is the intent of North Carolina. Particularly, our secretary has said that with managed care, we intend to improve the health and the well-being of North Carolinians. And we're going to do that in a whole person-centered way, making sure that our system is well coordinated and that we are addressing individual needs from a medical perspective, but also we're excited about the opportunity that this managed care initiative will give us to address non-medical drivers of care. And many of you have heard of these referred to as social determinants of health, or either our Healthy Opportunities program. Just as a point of reference, managed care implementation was mandated by some legislation that was passed by the General Assembly in 2015. For your reference, that's Session Law 2015-245. And that piece of legislation mandated that we implement managed care that will result in 1.6 million of the 2.1 million Medicaid beneficiaries being moved into the managed care system. With that managed care program, we will contract with prepaid health plans, which will offer either a standard care product, what we're calling standard plans, or in some cases, they will offer tailored plan products. Just a point of reference that I'll address later, tailored plans can only be offered by our current LME MCOs, our local management entities. For standard plans, beneficiaries will have the options to choose from 5 plans depending on where they live. There will be 4 statewide plans, and for individuals who are living in certain regions of our state, there will be an additional provider-led regional plan. I mentioned that the waiver that will cover the managed care program will allow us to pay for unmet social needs, and those include things like transportation, housing. The funds will allow us to address interpersonal violence as well as food insecurity as well. We have contracted with an enrollment broker. Maximus is the company, and their primary responsibility is to offer choice counseling. Individuals currently don't have to use a managed care company to access Medicaid services, and now they will, as of November 2019, have a choice of 4 or 5 plans. And then for people with serious behavioral health needs, They will also have local management entities that will become tailored plans. And so that's just to acknowledge that the system is becoming more complex. People will have more choices, and Maximus's role is to counsel people on those choices and give them information about that. Okay, this slide I won't go over in great detail, but you'll have access to the information later and can reference which individuals are required to participate in managed care and who is excluded. And just as a point of clarification, individuals who are excluded cannot participate in managed care. They must remain in their current system. And you'll see some individuals or the different Medicaid programs that are considered excluded. And then for anyone who's considered exempt, that means they have a choice to remain in the current fee-for-service program, or they can choose to go into a managed care program. And that is primarily, exempt individuals are primarily members of the federally recognized tribe, the Eastern Band of Cherokee Indians, or individuals who will qualify for tailored plans later, but who currently may want to move into a standard plans program. There are certain services that individuals will be able to access outside of managed care, and that's what we're referring to as carved-out services. And you see that those are listed here, dental services as an example, any services that are operated by our local education agencies or the Children's Developmental Service agencies. Just to provide a little bit more detail on tailored plans, tailored plans, as I mentioned, can only be operated by our current local management entities, MCOs, which currently operate our system. Tailored plans will go into effect in July of 2021, which is a little bit, about a year and a half after we go live with standard plans. The tailored plans must contract with an entity that has a standard plan contract for certain services. I will make a note that after the first 4 years that we go into managed care with tailored plans, the local management entities will have exclusive rights to operate tailored plans. But after that first 4-year period, then the tailored plans will be competitively bid, and a private company could offer a tailored plan. Tailored plans will serve specific populations, particularly those individuals who have serious behavioral health needs, those individuals with SPMI or children with serious emotional disturbances. There will be some services, state-funded services as an example, that are only available in tailored plan. Certain federal block grant services are also only available in tailored plan. And we will need to make some additional changes in legislation to make sure that some of our design for tailored plans can be realized. This slide just highlights for standard plans which private insurance companies will be operating across the state, and you see them listed here, the 4 statewide plans as well as the 1 regional plan that will operate in regions 3 and 5. The next slide, I think, shows you a map of what this looks like for the state of North Carolina. We are organized for managed care into 6 regions, but this slide demonstrates when we roll out managed care in November of 2009, which areas of the state, 2019, pardon me, in November of 2019, this slide demonstrates which counties in our state will be impacted. And then the final phase of our managed care implementation for standard plans will occur in February 2020, and that will be regions 1, 3, 5, and 6, which is in the lower part of the state. This timeline highlights some key activities and milestones for managed care. We have already been distributing educational materials to beneficiaries and doing a lot of general education to the public as well as DSSs. At the end of June, our enrollment broker will officially open its call center, and we will begin to distribute written materials to beneficiaries to let them know that they are required to participate and give them some written instructions about how they select a plan. Throughout the summer, the PHPs will continue to contract with providers, and as mentioned before, on July 15th will be our official open enrollment period. That will be a 60-day time period between July 15th and September 13th, during which members can choose which plan they want to have manage their care. If members don't select a plan during that open enrollment period, they will be auto-assigned. And we've defined some auto-assignment criteria, primarily focused on where individuals currently get services. If they're currently seeing a primary care physician, then they're going to be assigned to a plan where that physician is contracted, because we want to ensure continuity of care. But the open enrollment period just gives individuals an opportunity to make that choice for themselves. We mentioned that November 1st is when we will go live in 2 regions of the state, in Regions 2 and Regions 5, Regions 2 and Regions 4, pardon me, and then in February 2020 we will go live with the remaining regions in the state. A couple of key points, as you saw from the earlier slide, there are a small number of people who will remain in our current program, which we've branded as North Carolina Medicaid Direct. That's our current fee-for-service system. The services that are available to individuals will not change. All the Medicaid services that are currently available will continue to be available in the managed care environment. But some of the health plans will offer some value-added services. And smoking cessation, as an example, is one listed here. Some prepaid health plans may offer memberships to the Y or other kinds of programs. And as we go into managed care, the prepaid health plans are going to want to distinguish themselves from each other, and because all of them are required to offer all the basic Medicaid services, some may choose to offer value-added services as a way, again, to distinguish themselves. The rules for who qualifies for Medicaid will not change, and DSS will still retain responsibility for determining eligibility. I added this slide just to highlight a couple of key points. We recognize that this is a major change for beneficiaries, that there are some new complexities that are being added to the system, but our priority for when we go live on November 1st is that people will continue to be able to see the providers that they are accustomed to seeing, that they'll still be able to get the prescriptions and medications that they need. Providers will still have open doors and be willing to treat patients, and providers will get paid for the services that they deliver. Those are our bottom line priorities as we move to this managed care environment. A couple of things in terms of what we're doing right now within Medicaid is we are evaluating the prepaid health plan's readiness, and that means that we are looking at thousands of documents that they have submitted to us. We will go through a desktop review process. We will have in-person interviews in their offices. We will ask them to test. We're already beginning to test our systems, but we will also test their technology systems as well, with the goal of making sure that we are ready when we go live on November 1st. In addition to the prepaid health plans being ready, we are also evaluating our own departments and divisions readiness for being able to implement managed care. And so we are looking at NC Fast, we're looking at NC Track, and making sure that the technology is going to work when we flip the switch. Some of you have access potentially to some written materials that we've been made available. We've recently released some county playbooks, which includes fact sheets and other kinds of resource materials. We will have copies of the enrollment broker enrollment packet that is going to be distributed to members. We're going to make those things available to you all so that if you get questions from beneficiaries, you will know what written materials they have in their hand, and you'll have some lead time to be able to review those at your own convenience and even ask questions to us about them so that you'll be prepared for the managed care implementation as well. We're doing extensive training with providers, as I mentioned, with DSS, and as an example of what we're doing today with webinars, we want to make sure that the community is well educated about this change. And we're also continuing to add new vendors into our work. The Ombudsman is an example. We are currently procuring that Ombudsman contract, as well as an EQRO vendor, and that's the vendor that's responsible for evaluating quality of services that the prepaid health plans are delivering. Just a couple points about the Ombudsman. We had originally released an RFP several months ago. We didn't get any respondents, and so we reissued that RFP. The reason we did that is because the Ombudsman is going to be an independent entity that's available to assist people if they encounter problems when we go into managed care. And we wanted to make sure that we had an independent entity that would provide referral options to individuals, that would help them with problem solving, and would also be able to evaluate all of the entities that are involved in managed care and give information back to the department if people are experiencing problems, and to identify where those problems are happening across our system, so that as we need to make changes, we can do that. So the Ombudsman RFP is on the streets. We intend to award that RFP early in September, with the intent that the Ombudsman would be in place in November when we go live in 2019. I mentioned earlier about these county playbooks. They are available on the department's website. This slide enumerates some of the pieces of that playbook. We have a lot of fact sheets, and they're targeted towards DSS, but we find that there's a lot of basic and general information that others may find helpful as well. And so certainly go out to our website. If you type in county playbook, you'll be able to see these resource materials. Of particular interest to folks may be this instructional guide on our beneficiary outreach materials, because we have provided electronic copies of posters, flyers, palm cards that can be posted in people's offices that explains what managed care is and gives all of the timelines that I just reviewed. So those electronic versions of those materials are available in the second release of the county playbook, and we certainly want folks to be able to access that and put the materials in your office. In addition to that, we intend to have printed materials available in the Medicaid department, so that if people want copies of those posters, you can certainly reach out to me and we can get you copies of them so that you can post them in your offices. So in terms of what's happening now or what's happening next, is the enrollment broker will be continuing to train their staff. The enrollment broker, Maximus, will have an office in Morrisville. They are bringing staff on board in anticipation of their call center opening at the end of the month. They are training their staff as well as training their call center, their backup call center, to be ready to accept calls. The enrollment packets will start getting mailed at the end of the month. We're going to be sending out 500,000 copies of these enrollment packets, starting out with about 40,000 that will be mailed daily over the next coming weeks, beginning at the end of June. The enrollment broker will also have, just to back up for 1 second, the enrollment broker will also have some outreach events where they will have face-to-face opportunities for people to be able to enroll with the prepaid health plans. And we will post those events on our website, and just be on the lookout for those in the coming days. I wanted to highlight, because I know some of the audience participants are providers of services, we have an extensive list of webinars, resource materials available for you. I highlighted a webinar that happened just yesterday and a webinar that will be happening in June, a couple of weeks from now. The webinars, just as this one, have been pre-recorded and posted to our website. I think we're up to webinar number 8 at this point. So feel free to go to our website and access those. We have virtual office hours where our staff are available to answer questions. We just had one a couple of days ago, and we will have additional web office hours coming up. And then we have opportunities for providers to meet the prepaid health plans if you want to ask questions of them. That work is being supported by the AHEX. So feel free to go out to our website because you'll get an idea of where those events happen if you want to have a face-to-face conversation with the prepaid health plan. The next two slides are intended to be sort of a problem-solving resource for providers. If you experience some common questions from beneficiaries, we have given you some resources, either web-based resources or telephone numbers that you can call or give to the beneficiary to call if they have particular questions. And then the resources that are available to providers if you want to know how to locate a PHP, or even how to understand which PHP a member is enrolled with. Providers can access that information in the NC Track system. You'll be able to determine which PCP a person is assigned to, which providers can do today. And then if you want to find out information about prepaid health plans and information about managed care, we've provided those resources there for you. And that's a general review of the information that I wanted to offer. If anyone has any questions, I'm happy to take some now. I know that I went through that very quickly, but I wanted to allow time for questions.
Thank you so much, Deborah. I did see, it looks like we did have some questions chatted in.
The only new question I see from earlier is, does the exemption for vision service providers include ophthalmologists? I believe that was a question for me. And yes, it does include.
I see it in mine.
Yes, and also for managed care, there are some carved out services, and I think in an earlier slide, it talked about the fabrication, I think it's on slide 6.
Okay.
The fabrication of eyeglasses and eyeglass fittings is not a part of managed care. And so if that question relates at all to managed care, it is not the providers who are carved out, but it's the type of service that the beneficiary receives. And so at this point, the fabrication of the eyeglasses and the fitting is carved out, but the exams are currently, and it depends again on how the provider is coding their services, but some parts of the eye exam are not carved out. We are still working with the General Assembly to get all of the vision services carved out, but at this point it's limited to the fabrication of the glasses and the fitting.
If you have other questions for Deborah Farrington, thank you again so much for going over. I know, I'm glad that you left a lot of the resources there too, because I feel like just kind of listening to this information and going back and being able to even pause it and absorb it in is helpful.
Absolutely, and there's a lot of materials available to the providers, and you'll find that some of the information is repeated from one presentation to the next, but I think that's a good thing because it helps you to hear the information more than once and make sure that you've got it. The one thing I will say about the webinars, there's about 9 webinars on our website, is on each iteration there may be some clarification of information. Plus, in the instance of tailored plans, we are in the middle of designing tailored plans, and so information that wasn't available in April is now available now that we're in June. And so if you find any information that seems conflictual or that you have a question about it, feel free to reach out to me. We'll make sure that my contact information is available along with the slide deck so that if people have questions, they can follow up.
Great. It does look like a new one came in too. It just says, thank you again. So apologies if I missed this, but should behavioral health providers contract with PHPs now, so some beneficiaries will be on the standard plan that's being launched later this year?
That's an excellent question because behavioral health services will be available in the standard plan as well as in the tailored plan. The distinguisher is that people with mild to moderate conditions, behavioral health conditions, will be in the standard plan, and people who have more serious needs will be in the tailored plan. So to this question, providers of behavioral health services should absolutely be contracting with the PHPs now. We want the PHPs to have a robust network of providers. Currently, the LME MCO services, they cover, more than 1 million beneficiaries. When tailored plans go live, individuals who qualify for tailored plans will be between 115,000 to 130,000. So you see the vast majority of people with behavioral health needs are going to be in standard plans, and we want providers contracted with those PHPs. So absolutely, please contract with the PHPs, and if you need any support or have any difficulties with that, certainly reach out to the department. We want to make sure that that contracting process is going well.
Yeah, appreciate that. I know we did have one provider that said, for the most part, it has been smooth with most of the PHPs, but they have a little trouble with one of them, so I appreciate having a resource there to go to.
Absolutely, and what we've also heard today is that the LME MCOs currently negotiate rates with providers,
Okay.
and with the PHPs, they're starting with the standard Medicaid rate as their floor. But we have the rates that we are paying PHPs includes the negotiated rates that they have negotiated with the LME MCOs. So the PHPs have the experience and they have the money that the LME MCOs have paid, and so we want providers to know that and to negotiate with the PHPs from that position, that the PHPs are being reimbursed at the rates the LME MCOs have previously reimbursed providers.
Got it. One other question came in. Do current provider of Medicaid, I'm not sure if I told them like
with MCO need to.
Yes, and so if a provider is currently enrolled with Medicaid and delivering services in our fee-for-service program, if they are going to serve anyone in managed care, and that's the vast majority of people, they absolutely will still have to contract with the prepaid health plan. We're moving to a system where the provider enrolls with the North Carolina Medicaid program, but they contract with the prepaid health plan. So your contract will not be with Medicaid. The contract will be with the prepaid health plan.
Okay. All right, I think that's all the questions that we have in the chat for now, and I know we're really close to time, so thanks everybody. It was a lot of info to cover, but if you do have questions after this, we'll definitely share Deborah's information, we'll share the slides, and once again, this information is posted on our Office of Rural Health website. Your rural HIT specialist will be in touch with you, too, as we continue down the road to those that are still working towards EHR implementation and connecting to NC Health Connect, our statewide HIE. So even though it's our last webinar, we'll definitely still keep the connections open. If you do have other questions, we're around for a minute. We've got about a little less than 5 minutes before we drop off the call. You can chat those in for a moment. But great to know that, like you said, we've got a lot of these resources that are available even after the call, or if you weren't able to stay on for the whole time, this will be recorded and available on our website too. Anything else? I think I don't know if anybody had any epiphanies or questions around the table as we're here. All right, and it looks like chat is clear for now too. So we'll give you 5 minutes of your time back in your day. We appreciate you all joining us throughout this webinar series. It's been, we really do appreciate the feedback, and like I said, this is really, having Deborah here from Medicaid Transformation came from your feedback, because many of you had a lot of questions around, specific to behavioral health, because that's mainly who is part of this particular funding program. That's how we asked Deborah to come over and share this information with us. So we appreciate you guys' feedback. As Kenya was saying, just learning more about HIE. I know many people will join the How to Connect call more than once too, just because you'll hear something different each time. So just feel free to reach out to us if anything is needed. Well, everyone have a wonderful weekend. Enjoy the beautiful weather wherever you are in our beautiful sunny state here in North Carolina. And we will talk with you all soon. Have a great one. Bye-bye.